Can you hear me?
Yes, Dr. Sudha.
Yes, we can hear you.
Yes, we can hear you, Dr. Sudha.
Good morning, good afternoon, good evening to the veterinarian from the different region in the world. You are welcome to Sri Lanka Veterinary Association second international webinar series. We have organized 16 webinars at this second SLVA international webinar series. Our resource persons are well-reputed veterinarians in Sri Lanka and overseas. This is our 11th webinar. Today our topic is surgical intervention for congenital malformations in calves under welfare perspectives. Our resource person is Dr. Dammika Perera. He is a senior lecturer, researcher, and well-known scientist from Veterinary Teaching Hospital, University of Peradeniya. And our moderator is Dr. Tharindi Madivela, lecturer, Faculty of Medicine, University of Peradeniya. So now I would like to invite Dr. Tharindi Madivela to introduce our resource person. Thank you.
Well, thank you, Dr. Sugat. Good afternoon, everyone. Welcome you all for the 10th lecture of second international webinar series organized by Sri Lanka Veterinary Association. Today, you will be hearing from Dr. Dammika Perera. I must thank Dr. Dammika for accepting invitation to deliver lecture on surgical intervention for congenital malformations in calves under welfare perspective. Let me give you a brief introduction on Dr. Dammika. Dr. Dammika Perera has obtained his BVSc degree from Faculty of Veterinary Medicine and Animal Science, University of Peradeniya in 2004. Later, he earned his MPhil degree in Advanced Reproductive Biotechnologies from the same university. Further, he is a fellow of Sri Lanka College of Veterinary Surgeons and member of International Embryo Technology Society as well. During his postgraduate studies, Dr. Perera could establish the embryo transfer technology, embryo splitting technology, and embryo freezing technology in Sri Lanka. Besides, he is the person who has done the first successful artificial insemination of horse, while being the resource person of the first successful sheep AI project and sexed cattle semen AI project in the country. Dr. Perera has published more than 80 research and clinical papers locally and internationally during the last 17 years of time. He has been awarded more than 10 professional awards for his clinical and research and professional contributions, including Perumal Pillai Award, Dr. Hector C. Perera Memorial Award, Air Commodore Dr. R.M.P.A. Dasanayaka Award, and Dr. and Mrs. Muhammad Award from Sri Lanka Veterinary Association. Presently, Dr. Perera is working as a senior clinician of the Farm Animal Veterinary Teaching Hospital and a senior lecturer of the Department of Farm Animal Production and Health, Faculty of Veterinary Medicine and Animal Science, University of Peradeniya. Welcome you, sir. I would like to remind the audience that you can send your questions to our chat box and we will be answering the questions at the end of the lecture. Without further delay, I would like to cordially invite Dr. Dammika Perera. Over to you, sir.
Thank you, Dr. Tharindi and Dr. Sugat. I think all of you can see my screen.
Yes, Dr. Dammika, yes, we can see.
Right. Good morning, good afternoon, and good evening for everybody, considering the time zone right all over the world. So it's a great pleasure to discuss this information with you. Then I am going to discuss that about surgical intervention for congenital malformations in calves, considering the welfare perspectives. So as you know, as farm animal veterinarians, if you are working in a large scale farms, right, when you get that calf with congenital malformation, considering the management right convenience, we may cull that calf. So that is our basic policy, right? We may not consider about the another aspect of it, right? For the management convenience, we may have to cull that calves. But not only about the large scale farms, we have to think about the small scale farms. Sometimes, as you know, right, when you go to the field, right, there are many backyard systems, a household system, different small scale farms are there. So as you know, those farmers are very close with their animals. They may have few cows with them. Sometimes they are calves, and cows may be a pet for them, right? Not only for the production, right? They may rear those animals as pets, so they may have a close relationship with those animals. So when they get calves with congenital defects, so they may not allow us to cull that animal, right? Or they may not consider that aspect. They may come to you asking any solution to save the life of that animal. So that is their thought, that is their vision, so that is their requirement. So they may expect something from you to save the life of that calf, or to save the or keep that animal without culling. So under that circumstance, we should have, as veterinarians, as professionals, we should have some solution for our clients, for their satisfaction, and considering about the welfare aspect of the cows, we have to consider about even those aspects without going for the culling policy in such a situation. So under that circumstance, we have to consider about these kind of surgical involvements. So then in this discussion, I will discuss about following topics: Atresia ani, rectovaginal fistula, anorectal agenesis or the colostomy as the solution for that, then removal of the tumor located around the rectum, and fixed carpal joints. Then as the solution, we may discuss about the surgical solution for that. That is about carpectomy and partial arthrodesis. So I will discuss those things within next 1 hour time. When you look at the first topic, Atresia ani, you may get complaint from the farmer within first few days of the life of that calf. It is related only with neonatal stage. You may get that kind of complaint regarding the neonatal calves. So complaint would be lack of defecation, or sometimes lack of anus. Sometimes certain farmers may notice that. So then in addition to that, sometimes they may complain about hyperexia or the reduced appetite. Then they will complain about those aspects. Then in your clinical examination, you may able to identify the defect there. Then not only that, as you can see here, as you can see in this diagram, this is the you imagine this is the end part of the GIT or the rectal area, it has originated from the endoderm at the embryonic growth. So that skin part may originate from the ectoderm. So then at the embryonic development, both that ectodermal and endodermal origin, or the GIT, end of the proximal end of the GIT, gastrointestinal tract, and the skin should fuse together, when I explain it simply, and leaving an orifice there, that is the anus. So sometimes with the embryonic developments, that may not happen. So in that case, so that externally we may able to see animals without anus, as you can see in this picture. So then we have to find a solution for that. So then we have to, one thing is we have to observe the protrusion or the bulging of that probable location of the anus, So this is the area that you have to check, that just below the level of the base of the tail, you have to check whether it is protruding or bulging, So as you can see in this picture, sometimes in this first picture, sometimes you may see that permanently bulged or protruded, that area associated with the probable anus. So in that case, it is very convenient for us. So that bulging would be due to accumulation of the meconium within the anal pouch, although that rectal pouch, that anal opening is not there. So in that case, we can cut open and we can make the artificial anus for the animal. But sometimes again, we have, when you observe that area, sometimes you may notice that intermittent bulging of that place, not always, right? Especially while animal is straining, then you may see that protrusion of the, or the bulging of that probable anal area in this part, right, as you can see in this second picture, right? Then again, it is convenient for us. It means that anal pouch or the end of the rectal pouch or the end of the rectum is very close to the skin, right? Then again, we can cut open and we can make the artificial anus for the animal, right? So then sometimes we may not able to see the bulging even at the straining of the animal, right? Under that circumstance, we may have to think about the other possibilities even, right? Anyway, presence of atresia ani conditions, then we can try to find the presence of that rectal pouch, right, which has accumulated with meconium. For that, we have to pass 18 to 14 gauge needle, right, across the probable location of the anus. Then we have to aspirate. Then we can see if we can find that pouch very close to the our needle or the close to the probable location of the anus. Then we can see the aspiration of meconium to the syringe. Then we can understand the depth of the location of it, right? So then we have to go for the surgery. For, as you know, before the surgery, usually we have to keep that animal in fasting, right, for a certain period under different situations. But in this situation, right, they are neonates, right, neonatal calves. We don't want to keep those animals for fasting for prolonged period. So instead of that, without keeping that animal for fasting, we can go for the sedation and anesthesia according to our requirement. Because when you keep those animals for fasting for prolonged period, sometimes that calf may die because of the hypoglycemic situation. So they are highly sensitive for that situation. So considering those aspects, we should not go for the fasting period, right? So without doing that, we can directly go for the sedation. We can use, for an example, we can use xylazine, 0.05 mg per kg intramuscularly. Then for the anesthesia, we can use general anesthesia. For that, for an example, we can use ketamine, 6 mg per kg in IV route, right? Or else we can go for the posterior epidural analgesia using 2% lignocaine. We can use 2 mg per kg, right, dose rate. Then we can introduce it through the same route, as you know, right, in between C1, C2, right, space or the sacrococcygeal junction, right? Then after the anesthesia, we can do the start the surgery. So at the surgery, right, we have to prepare the surgical site. So surgical site mean we have to find the probable location of the anus. Then we have to prepare the surgical site, as you know, as we are doing in our routing surgeries. We have to clip and we have to clean the site. Then we have to scrub the site with 70% isopropyl alcohol, 4% chlorhexidine or 10% povidone iodine. Right. Then we have to scrub the site. Then we have to make skin incision. First incision should be in vertical axis. Then another incision in horizontal axis, right, on the expected site, as you can see here in this place. So then we have to first cut through the skin, then subcut tissue. Then we can see the rectal pouch there. Then once you identify the rectal pouch using an artery forceps, we can exteriorize it. Or if it is more superficial, right, without using the artery forceps, we can open up it, right, while holding using Alice forceps. So then pouch, then we have to make mucocutaneous junction artificially. It means we have to put stitches or the sutures of rectal wall, right, or then against the skin. For that, we can use simple interrupter suture pattern with non-absorbable suture types. For an example, we can use 0.45 G gauge nylon for that, right? So we have to, anyhow, we have to keep the mucosal layer of the rectum against the skin. Then we have to put the stitches to make the anus artificially, right? Then as usual, we can we have to do the post-operative care. For that, we have to apply tincture of iodine on the. It's better to use penicillin group as the first line antibiotics for the surgeries. Then we have to consider about the pain of the animal. For considering that, we can go for the analgesics, NSAIDs, or the glucocorticoids, right? So then we have to have close observation about the surgical site until at least 1 week period, because that animal may defecate through that opening. It is highly vulnerable for the contamination, so maggot infestation, suture adhesion, bleeding, so many possible complications are there. So considering those aspects, we have to have a close observation of the animal, and it means we have to keep that animal in a separate place until the fully recovery. Then next condition is rectovaginal fistula, right? So another development of the congenital conditions. So here in this case, sometimes farmers may not come to you few days after, even few days after calving, right? So because farmer may notice that defecation, urination, right? Because of that, farmer may not worried within first few days, but with the time, within after several days, farmer may notice about the defecation through the vulval lips, or coming through the vagina, right? Then in that case, he or she may come to you, right? Then with the complaint of that. Then we have to identify the fistula. For that, we can pass our finger through the vagina towards the upright, or we can pass a blunt instrument, right? So then we can we have to insert through the vagina. Then we can feel the opening of the fistula from the vaginal side. Then we can find the proper place. As you can see in this diagram, most of the time that fistula may locate posteriorly, very close to the perineal region. So in that case, to correct this, we have to as I mentioned earlier, we have to follow the anesthetic guidelines. Then we have to prepare the surgical site, as I mentioned earlier. Then we have to put the incision starting from the dorsal commissure of the vulval lip here, dorsal commissure of the vulval lip through the perineal region. It means we have to cut through the skin, subcut tissue, and the fistula, across the fistula like this, along the fistula, up to the rectum. Then we have to cut the skin part up to the level of the probable location of the anus. Then we have to separate this fistula. We have to separate the rectum from this fistula, and we have to extend that opening up to the required level. And we have to put mucocutaneous. We have to make artificial mucocutaneous junction using the previous skin incision here, right? Then meantime, we have to close the fistula from the vaginal side. For that, already we have opened up into the fistula. Then we have to scarify this fistula opening from the vaginal side until bleeding. Then we can make a fresh wound there. Then we have to put stitches to close the fistula opening in that point. After that, we can close the skin incision, right, close to the associate with the vulval lips here, right? That way we can correct the fistulas. So that's how we should do the correction of fistula in farm animals, right? Then next one is anorectal agenesis. Anorectal agenesis. So again, to explain that, I will use the this real case, right, that we have involved. So when you look at the history of that case, we got a 3-day-old bull calf without rectal opening. Without rectal opening. It was a referred case from a field vet after unsuccessful right surgery to rectify that matter or to correct the atresia ani. So finally they referred that case to us. Then we have done the GCE. It was right normal except this complaint. Then we have done the sedation anesthesia. We have handled this case under general anesthesia, right, as I mentioned earlier. Then before do the rest of the surgery, we have done the aspiration using 16 gauge 2 inches lengthy needle, but unfortunately we couldn't see that right first feces. We couldn't aspirate it. So then it means that rectal pouch would be little away from the right expected level of the right place or the expected place of the anus. So that our needle was 2 inches lengthy, but we couldn't get that. So with that clue, we have decided to go for the, we have to we have to think about the other right possible corrective measures, right? So then then we have decided to do the laparotomy from right lateral right abdomen, not the paralamba fossa. We have done it from the right lateral abdominal area. Then after doing the laparotomy, we have done the identification of rectal agenesis, probable rectal agenesis. After doing the surgery, as you can see in this first diagram here, we have inserted hand up to the right level of the towards the rectum. We could feel this pouch, right? After that pouch, we couldn't feel the right rectum there. So instead of that rectum, we could feel that small band, right? Diameter was around 3 millimeters, a band, right? Continuation towards the probable location of the anus. So then that could be due to rectal agenesis. So that right, it has the development has ended up with the level of the colon. So then we have to think about the right other possibilities. Then we have decided to do the colostomy for as the corrective measure. For that, we have, as you can see in this second diagram, we have exteriorized the part of the right pouch here, right, part of the colon. Then we have squeezed back the right content, right, backwards. After that, we have applied the bowel clamp, as you can see in this diagram. Then, as you can see here, right, after application of the bowel clamp, then we have done the colostomy parallel to the laparotomy incision, right? Then with that, as you can see in this first picture, right, this is the right colon, this is the laparotomy incision. Then we have made a mucocutaneous junction artificially, right, using the mucosal layer of colon and the skin of the abdominal area. So using the non-absorbable, again, non-absorbable suture material, nylon, or we can use a simple interrupted suture pattern for that, right? That is more steady, more stable for the right condition. Then we have used that. Then again, we have to do the post-operative care, right? As I mentioned earlier, right? We have given antibiotics and analgesics, wound dressing for until 1 week time. So we have done that part. Then with the fully recovery, we have discharged that animal, right? 7 days of hospitalization period, right? So this is the animal, right? Here you can see animal 3 weeks after the surgery, right? From its original location, right? So here you can see the surgical site, right? This is after 3 months from the surgery, right? Still animal is there without any right complication, right? Here you can see the place that we have done the right opening, right? That's how we can rectify those matters. Then we'll move to the next method, right? Considering about the removal of tumor, which has located around the rectum. Sometimes you may get that kind of cases, right? As you can see, again, to explain that condition, I will use this real case, right? As you can see in this picture, here you can see that protruded rectal area, right, with the anus, right? If it is not much clear in this picture, here you can see in this second picture, right? You can see the protruded rectal area. This is the anus, right? So when you look at the history of this case, it was a 2 years old female Frisian heifer. So then presence of inability to perform the per-rectal examination at the artificial insemination, they have informed to the owner. But the interesting thing is that owner has identified that situation already, right? They have noticed it even from the beginning, but he has not understand it. So as a beginner for the livestock farming, he has not understand it. So that was the problem here, right? After 2 years of the age, then they have complained it to us. So that at the clinical examination, we could find these changes. So at the clinical examination, we could feel round, firm mass around the posterior rectum with narrowed anal space. We could feel that firm circular structure, which has located around the rectum. Because of that, rectal or the anal opening was very small. Diameter was around 1 centimeter. So at the defecation, animal have been suffering due to the difficulty of that. So then we have decided to correct it surgically. So at the correction, we have done pre-anesthetic medications for the animal. Under that, because we have to do the surgery around the anus, so there's a high possibility to contaminate. Considering those aspects, we have given magnesium sulfate 2 days prior to the surgery. Then meantime, we have kept that animal for off food for 2 days, then for water for 12 hours. During that period, we have given IV route supportive therapy, 10% dextrose, LRS, and other supportive therapy to compensate the requirement of the animal, right? Then at the surgery, we have done the sedation and anesthesia using 2% xylazine HCl, following the mild sedation. It means 2.5 mg per 50 kg intramuscularly. And we have done the surgery while animal is in standing position. For that, we have used posterior epidural analgesia, then using 2% lignocaine HCl. We have used 2 ml, but as you can see in this picture here, we have fixed the syringe, which contain 8 ml of lignocaine. Then we have released 4 ml of lignocaine at first, right? But we have maintain it on the same side without removing, right? So as you already know, at the induction of the posterior epidural analgesia, we have to pass this 18 gauge needle in between sacropoccygeal junction or the C1 C2 junction, right, until the epidural space. So we have to verify whether it has gone to the epidural space or not. To verify that, we can do several things. As you can see in this picture, we can put a few drops of lignocaine to the hub of the needle. Then if it is going towards the epidural space freely, the site is correct. Or else we can try to hear the pop sound while inserting the needle there. Or else we can connect the syringe and we can aspirate it. Then you can see the bubbles, air bubbles coming to the syringe. And meantime, we can try to pass the lignocaine. Then if it is in the proper place, you should be able to release the drug without any resistance. So other thing is, when you aspirate, there should not have blood, right? When you insert that needle into the subarachnoidal space, then you will see the bleeding, right? So considering those factors, we can do the posterior epidural analgesia. Then we have started the surgery. As you can see in these pictures, first we have to wash and scrub the surgical site. Then at the surgical procedure, we have done the circular skin incision, right, around 1.5 inches away from the present anus, right, circular manner, as you can see here. After that, we have done the blunt dissection between the probable tumor growth and the surrounding tissue using artery forceps and blunt-ended scissors. So then we exteriorize the rectum with tumor mass, as you can see in this second picture. So here you can see the anal opening. This is the tumor mass. Right, we have separated the rectum from the body and we have exteriorized it. Right, then we have separated the tumor mass from the rectal wall. So then we had to remove the part of the.
Excuse me, Dr. Dammika, I think slides are not moving now. Can you check?
So what is the slide that you can see here?
The laparotomy, right lateral abdomen. That's that one. Identification of rectal agenesis.
I see. So it means about the previous slides. Can you see that picture with the kid?
No, still the previous one. I think you need to stop sharing and reshare. No? Can you? Because it's not moving.
Yes, Dr. Dammika. Better you stop sharing and reshare.
Yeah. What about now?
Now we can't see any slides. And now we can see a slide with a kid.
All right.
3 weeks after surgery.
Right. Then so previously you could see this picture, no?
No, this is the first time.
I see. So this one?
That is the calf one. That one is colostomy parallel to the laparotomy.
Yeah. Could you see that previously?
No. That one, this one, this is the slide we are watching.
Right. Okay. I'll quickly go through this. Then, as I explained earlier, here we were talking about the colostomy surgery, right? As you can see in this picture, right here you can see the colostomy that we have done parallel to the laparotomy here. Then we have put stitches or the sutures keeping that mucosal layer of the colon against the skin, and we have applied sutures, leaving an opening here, right? So in second picture, you can see the surgery here. I think you can see it now. In second picture, this picture, you can see the opening clearly, right? Immediately after the surgery, right? So here you can see the after application of the wound dressing compound here, right? We have kept that animal for 7 days. Then after the 7 days with the fully recovery, we have discharged that animal. Then here you can see that animal after 3 weeks from the surgery, from its original or the site or the place or the farm, right? Then here you can see the same animal after 3 months after the surgery. So here I'm going to talk about that removal of tumor around the located around the rectum. Sometimes you may get this kind of complaint. To explain that, I will use this real case that we have handled. When you move to the history, it was a 2 years old female Frisian heifer, right? Due to inability to perform the parental examination at the AI, they have complained it. They have informed it to the farmer. Then that interesting thing is, farmer has noticed that even from the very beginning, it means at the neonatal stage, but he has not worried about that because he was not much aware about this farming as a beginner. Then finally they have referred that case to us. Then in our clinical examination, we could find that round firm mass around the posterior rectum. So here you can see the protruded rectal area with a bigger mass. So then here you can see the very narrow rectal opening, right? When we check the rectal opening, we could insert only one finger through the opening. So diameter was around 1 centimeter. So then we have decided to correct it surgically. Under that situation, we have given pre-anesthetic medication to the animal because we have to do the surgery in a well-developed animal, and we have to do the surgery associated with the rectum, so it is highly vulnerable for the contamination. So considering those aspects, we have given magnesium sulfate orally, 200 milligram of magnesium sulfate dissolved in warm water. Then we have given it as lukewarm water solution. Then we have drenched 6-7 bottles of water, and we have provided enough ad libitum water to the animal. Then we have kept that animal fasting for 2 days, and for water we have kept that animal for 12 hours. During that period, we have given 10% dextrose, LRS, and saline to compensate the requirement of the animal. At the surgery, they have done the sedation using 2% xylazine with mild sedation using 2.5 mg per 50 kg intramuscularly. So we have done the surgery while animal is in a standing position using posterior epidural anesthesia. For that, we have used 2% lignocaine HCl. We have initially used 4 ml lignocaine, as you can see in these pictures. I think now you can see that slides. So after induction of that, we didn't separate the syringe. We have kept it with the additional amount of additional 4 ml of 2% lignocaine there, right? Because we couldn't estimate the required time. So if it's a long-lasting surgery, we have to introduce more. So while you are doing the epidural analgesia to the cow or the calf, we have to insert 18 gauge hypodermic needle in between sacrococcygeal junction or the C1 C2 junction. Then before release the drug, we have to make sure whether you have passed that needle into the proper place or the epidural space. To make it sure, we can, while you are passing the needle, we can try to hear the pop sound. Then if it is in the proper place, you can hear the pop sound, or else we can, as you can see in this picture, we can put few drops of 2% lignocaine to the hub of the right needle. Then if it is in the proper place, freely it may move to the right epidural space, or we can connect the syringe into the hub and we can aspirate it. Then you will see bubbles come into the syringe, or else we can try to release the drug. Then if it is in the proper place, you should be able to release the lignocaine without any resistance. When you aspirate, if you can see the blood, it means you have passed that needle into the right subarachnoidal space. So we have to adjust under that situation. So then at the surgery, we have done the right, we have washed the surgical site, then we have scrubbed it, then we have done the circular skin incision around 1.5 inches away from the rectum. So then circular manner, then we have done the blunt dissection between tumor and the probable tumor and the surrounding tissue. Then we have exteriorized the rectum with the tumor mass, as you can see in this second picture, right? This is the right anal anus. Here, this is the right probable tumor mass. We have separated from the body. We have separated the proximal part of the GIT from the body. So then we have separated the tumor from the rectal wall. So, but unfortunately, we have to remove a part of rectum, most posterior part of the rectum, due to the weakness of that wall, right? So very thin, weak wall, presence of thin, weak wall, we have decided to remove that part, right? Then we have, using the remaining edge, we have made an artificial mucocutaneous junction right in this surgery. So then after that, we have to do the right post-operative care very carefully, right? We can use antibiotics, tetanus toxoid, then analgesics, NSAIDs, or glucocorticoids. We have to do the right wound dressing until fully recovery, right? We have to have close observation to prevent the contamination, right? And then we have to, here you can see the right removed tumor mass. Here you can see the the part of the rectum that we have separated, removed, right? So then here you can see the new edges of the proximal part of the GIT. Then using this mucosal layer, we have done the we have made the artificial mucocutaneous junction using non-absorbable type suture material using nylon, 0.45 nylon. So then here you can see the picture immediately after the surgery, right? Now here you can see the considerably bigger opening here. This is immediately after the surgery. This is 2 weeks after the surgery, right? So before discharge the animal, after the fully recovery, we have checked whether we can insert our hand per rectally or not. So with that, with the successful surgery, we have discharged that animal. Not only that, we have sent that tumor, or the probable tumor sample for the pathological diagnosis. Then according to the histopathology, we could diagnose it as fibroliomyoma, right? That's it is possible, right? It's a possible tumor, benign type tumor, which can organize around hollow organs, especially vagina, rectum, then uterus, right? Organs like that. So fifth one, so last technique is correction of flexed forelimb, especially at the carpal joint, right? So again, to explain that, I will use this real case. When you look at the history, we got that 20 days old Frisian Jersey Sahiwal crossbred female calf. So the complaint was inability to extend the left forelimb at the carpal joint since birth. So in our GCE examination, we couldn't find any abnormality other than the complaint. So then so we have taken an X-ray but unfortunately it was right having very low diagnostic value due to the certain errors in that images. But with the close examination of the X-rays, as you can see here, and with the palpation, we have drawn, we could identify certain defects there, according to that findings and feeling, we have made this image, considering about the possible malformation in the carpal joint here. So then according to our identification, so as you know that in the carpal joint there should have two layers of carpal bones, so proximal layer and distal layer. Then within that each layer there should have 3 carpal bones, so medial, lateral and mid. So then there totally there should have 6 carpal bones in the carpus. So but according to our identification diagnosis, we could feel like that. Other than that, carpal bone should locate across the carpal joint, but here we could feel only at the anterior part of the carpal joint. We couldn't feel 2 layers there. So then we have identified it as like this. Then so we have to we have decided to do a surgery to try to correct it. So then we have done the sedation and anesthesia, as I mentioned earlier. We have done this surgery under general anesthesia, using psilocin ketamine. So as you can see in this picture, we have done the vertical incision along the carpal joint. Then meantime we have done horizontal incision as well across the carpal joint here, initially on the skin. Then we have opened up until the carpal joint. So while we are doing that incisions, we have to cut certain other structures as well. So we had to cut tendon of the extensor carpi radialis muscle, then accessory cephalic vein, branches of the radial artery, then part of dorsal arterial plexus. Those are comparatively blood vessels are minor type blood vessels, though there's a possibility to for anastomosis. So then we have separated those part. Then we have opened up into the joint through the joint capsule. Then we have done the carpectomy. We have removed the carpal bones. As we guessed, we could see only 2 carpal bones, as you can see here, medial and lateral. Only 2 carpal bones instead of 6 carpal bones. Then we have decided to remove that part, carpectomy. Then separated the interosseous ligaments using a scalpel blade, and we have removed both medial and lateral carpal bones, as you can see in these pictures. So after that, although we have tried to extend the limb, it was not sufficient. Then under that situation, we have decided to do the partial arthrodesis. So in then epiphysis of radius ulna and metacarpal bones. As you can see in this picture, I think you can see my slide. Am I correct?
Yes, sir, we can see.
Right. As you can see in this diagram, you may pay your attention on these white lines, so that was the expected incision line across the epiphyseal part of the bones. We have decided to remove a slice from both the radius ulna side and metacarpal side. Then we have removed the wedge shape slices from the cranial epiphysis to mid of the articular surface, not totally, not across the entire epiphysis, only up to this level, in a wedge shaped manner. As you can see in these real pictures, we have cut and removed these 2 wedge shaped bony parts, So then we could extend the limb up to the expected level, Then we have removed the excess part of the joint capsule, overstretched part of the joint capsule. Then that remove the excess part of the tendon of the extensor carpi radialis muscle and the skin. Then we have applied sutures to the joint capsule, then to the extensor tendon of the extensor carpi radialis muscle. Especially when we apply sutures to the tendons, we have to use tension type sutures. Here we have used that cross mattress type. So instead of that, you can use the far, near, far, near, far, right? Different types of tension sutures are there. We can apply one of that for the right tendon. Then we have close the right skin using right non-absorbable type suture materials. So then again, we have done the post-operative care very carefully until fully recovery of the animal, right? So then not only that, after the surgery, as you can see here you can see immediately after the surgery, right? Then we have provided additional support externally. For that, we have specially prepared this metal splint. Then we have wrapped it with cotton wool. Then we have fixed it, as you can see in this third picture, right, to the limb, right? Then we have removed that after 2 weeks from the surgery. Here you can see the surgical site 2 weeks later. Then this is 1 month after the surgery, right? We have without any external support. Animal started to use that leg while walking. So then when we compare with the other leg, right, it was 0.75 inches, roughly 0.75 inches shorter than the other one, but animal used to use that leg without any trouble. So to get more information, you can go through this website and YouTube. So then you can see the relevant videos and the papers regarding that. And thank you very much. Especially, I would like to extend my sincere gratitude to the different owners of several pictures, because I have taken few pictures from the internet to explain this. So I must thankful for the real owners of that pictures and the organizing committee and all the participants. So if you have any clarifications, you are welcome for the questions. Thank you.
Thank you very much, sir. That was an interesting and comprehensive lecture, sir. I must thank Dr. Dammika Perera on behalf of Sri Lanka Veterinary Association for his valuable time and dedication to enlightening us on surgical interventions for congenital malformations in cows under welfare perspective. Now it's time for the questions and answers. You can unmute and ask questions directly from sir or type in the chat box and we will be directing to the sir. All the questions are welcome. So may I ask a question?
Sure.
So regarding the rectal agenesis case, are we going to keep that stoma permanently or any Hartmann reversal? If you are going to do Hartmann reversal, what the duration we are doing after the surgery?
No, I think in large animal practice, we may keep as it is.
Okay.
Right. So because not like in that small animal practice, we may do for considering about the animal welfare and the animal conservation, right? So we may keep it as it is.
Thank you, sir. Any other questions from the audience?
So if you have any questions, you can type even in the chat box. I can see that directly.
If there's no more questions, it's time for the conclusion of the session. I must thank Dr. Dammika Perera, our resource person, once again for his valuable lecture and also my enthusiastic and supportive audience. I would like to invite the Honorary Secretary of Sri Lanka Veterinary Association, Dr. Chamari Kannangara, to proceed with the rest of the session. Over to you, Dr. Chamari Kannangara. Thank you.
Thank you very much, Dr. Tharindi. On behalf of Sri Lanka Veterinary Association, I would like to thank today's speaker, Dr. Dammika Perera, for accepting today's invitation. Dr. Dammika Perera is one of our executive members of Sri Lanka Veterinary Association, and Dr. Dammika Perera has done so many previous lectures also, because he has attended one of our workshops and he's attending next workshop also as the resource person. And also Dr. Dammika Perera already concluded a session regarding scientific writing. So Dr. Dammika is always willing to help Sri Lanka Veterinary Association, and he's always sharing his knowledge to uplift the veterinary profession in Sri Lanka. So thank you very much, Dr. Dammika. And today it's excellent presentation with a lot of colorful pictures and all. Most of the photos are your own experiences. So it's very helpful to our audience, especially today there are a large number of students attended today's webinar. So I'm pretty sure that they have gained a lot of knowledge about today's presentation. So once again, I must thank Dr. Dammika, and I hope you will assist us in our future programs as well. And next, I must thank Dr. Tharindi Madivela, today's moderator. Thank you, Dr. Tharindi, for your voluntary service to be the moderator today. And thank you very much, Dr. Tharindi, again. And next, I must thank all the audience who have participated today's webinar, those who have joined from Sri Lanka as well as from other countries, especially South Asian countries. So thank you very much for your presence today. And also, I must thank our executive committee members of the Sri Lanka Veterinary Association, even though our president is not physically here today because he is attending a conference in Nepal. So I must thank our president as well as all the other executive committee members for your continuous support given for us to continue this webinar series. And also those who have joined, like the students, I must tell them that if you have missed any of the webinars, even today webinar and all the previous webinars, all those webinars are available in Sri Lanka Veterinary Association YouTube channel. So especially the students who have joined today, they can watch all these webinars by logging into SLVA YouTube channel or SLVA website, and also the SLVA Facebook channel. So they can also tell their friends to join our SLVA website and watch all the previous webinars, because I am sure these webinars, you all can see all those webinars later. So when you have any problem in field level, so you can go back to the webinar series and watch those webinars. By that also you can gain a lot of knowledge. So that is one of the objective of having this webinar series by Sri Lanka Veterinary Association, because it's an assist, because anytime, even not only this webinar series, the first webinar series which we had earlier last year, that one also you can watch by logging into SLVA YouTube channel. So thank you very much again, and I welcome and I invite all of you to join our next webinar. The speaker is the same speaker, Dr. Dammika Perera, and this is different. This is about equine medicine, and the topic is how to manage the tendinitis in horses. So it is regarding equine lameness. The webinar will be held on Sunday, next Sunday at 1:00 p.m. Sri Lanka time. So I invite all of you to join our next webinar, and thank you very much